Okay, shall we start then? Can you all hear me? Hello, can you all hear me? Okay, right. First question. There are 20 true false and the 30 SBRs. We'll try to finish as much as possible. Right? First question. If you all can't hear me, let me know, right? Then just unmute and tell me. Right. First question. Regarding a woman who has undergone anti-resection. First one, anastomotic leakage occurs on post-operative day 1. This is false, right? Usually anastomotic leakage occurs on post-op day 5, right? Unless you have a huge technical error in doing the repair. Usually we assume that the technique is all right. 10 to lesions, anastomotic lesions occurs in usually day 5 onwards, right? The lung post-op day 1 fever can be due to basal lung atelectasis. Now, thing is, according to previous teaching, lung atelectasis was a cause for post-op fever, but now we don't take it as a cause for fever. Atelectasis is a cause for post-operative hypoxia, but not for this. It doesn't cause fever, right? There's no significant correlation between post-op fever and the atelectasis, right? That is the recent evidences. If you go through the up-to-date atelectasis, you all can see my screen, right? Can you all see my screen? Can you see my screen? This update. Okay, right. This is atelectasis describes a loss of lung volume due to the collapse of lung tissue, right? It can be either obstructive or non-obstructive, right? It causes post-operative hypoxemia, cause hypoxia, but there's no correlation between post-op fever and the atelectasis, right? That is the recent evidences. If you go through the articles, you can find that, right? Let's see. Hypokalemia is a cause for basal lung atelectasis. No, it's false. Hypokalemia is a cause for paralytic ileus, post-operative paralytic ileus. Basal lung atelectasis mainly, there are two mechanisms, either obstructive or non-obstructive, right? All feeds are delayed till flatus pass. That is old technique. According to ERAS protocol, now we tend to start oral liquids as soon as possible, right? We don't wait till the ball sounds of pure flatus pass, right? That is all practice. Earlier you start feeding, that will increase the gut motility, right? And prevent the gut bacterial translocation. So that is the practice according to the evidence-based medicine, right? And you should know this. What do they meaning by anterior resection? That is a major surgery you do for rectal carcinoma excision, right? 1B answer again. Post-op day 1 fever can be due to basal lung atelectasis. Usually, it was according to previous teaching, atelectasis was the cause for post-op fever, day 1 fever, but according to new evidences, atelectasis and post-op fever doesn't correlate. There's no interaction between atelectasis and the fever, right? Atelectasis usually causes hypoxemia, not the fever, right? 1A, anastomotic leakage usually occurs at day 5, not the day 1, right? It will go through this post-operative complications, right? According to the post-operative pyrexia, common surgical complications post-operative period. This is the chronological order, right? Basal atelectasis occurs on usually day 1 or 2. Thereafter, infection occurs, right? Infection arises. And these hemorrhages, hypolemia, electrolyte disturbances, those occurs from day 1 itself. Urine retention usually goes from day 1, right? From day 2 onwards, acute kidney injury may arise, right? The nausea, vomiting, ileus, abdominal compartment syndrome usually occurs from day 1 itself. Anastomotic leakage, fistula formation, usually arises from day 5. Okay. Infection, with regard to infections, wound infection usually arises from day 3. Deep infection from day 5, right? Then post-operative complications, you usually classify according to the time of onset: immediate, early, and late. Immediate means complication which arises within the first 24 hours after the surgery. Early complications arises within 30 days. That means after day 1 can arise from day 2 to day 30. Late complication after 30 days, right? And principles of management of complications: risk assessment and try to prevent, and if it arises, early recognition and immediate management, right? And that's regarding post-op complications. Regarding post-operative pyrexia, post-op fever, there are non-infective and infective causes, right? Mainly non-infective causes for post-op fever are surgical site inflammation without infection, such as hematoma, suture reactions, then DVT, fat embolism, inflammatory causes like gout, pancreatitis, then MI, bowel ischemia, and again drugs, right? There's a malignant hyperthermia, as you may have heard of, due to this anesthesia drugs. Then endocrine causes such as hypothyroidism, hypoadrenalism, and transfusion-related reactions, transplant rejections, alcohol withdrawal can lead to non-infective. Those are non-infective causes for post-op fever. Infective causes, common as are surgical site infection, pneumonia, and UTI. Again, it can be due to catheter-associated, IV catheter-associated infections, antibiotic-associated diarrhea, transfusion-associated viral infection, and foreign infections, right? So the major classification of causes which leads to post-operative pyrexia, right? Right, that bit is enough for first question. Anastomotic leakage, you should know. You can hear me, no? Is it clear? Right. You should know what is an anastomosis and what are the causes which leads to anastomotic leakage, right? It's if you do a bowel anastomosis, this healthy edges of the bowels which are going to anastomose should be healthy, and vascular supply should be adequate, and repair should be tension free, right? Correct technique should be followed. and it should be, anastomosis should be done away from an infective site. If there's bowel perforation and cross-contamination of the peritoneal cavity, you should take your anastomosis site away from that infective site, right? Those are basic surgical principles. We have anastomosis. Definition is a surgical union of a hollow viscera. It could be a GIT, pancreatic or biliary, vascular or GU. You do vascular anastomosis, intestinal anastomosis, and you do this pancreatic or biliary anastomosis in Whipple surgery, and in GU surgery you do this ureteric anastomosis, right? Indications: after resection to restore the continuity, you should anastomose, right? Bypasses, diversions, afistular creations, all these conditions you do different sort of anastomosis, right? Factors affecting successful healing: there are local and systemic factors. Local factors, you should avoid ischemia, infection, and distal obstruction and tension. Anastomosis should be tension free, right? And systemic, this causes hypoxia, anemia, diabetes, malignancy, steroids, all leads to poor wound healing, and you should avoid these factors as much as possible, right? These are the principles just to go through. Edges should be healthy, good blood supply should be there to the ends of the anastomosis, right? And it should be tension free, and lumen sizes should be matched and prevent constrictions, and orientation should be correct. You should avoid twisting, right? And correct suture materials. Right, those are the things, right? Okay. Then, second question. 55-year-old female who underwent a left mastectomy with axillary clearance complains of severe pain at the surgical site after 8 hours of the surgery. Acceptable pain management options. This is acute pain, post-operative acute pain management, right? Diclofenac suppositories, IM morphine, pethidine, and paracetamol all are options, right? Gabapentin, usually you give for neuropathic pain, that is chronic. Usually you give for chronic pain, right? That is after 2 weeks of the acute pain. So apart from C, all others are true, right? And IV pethidine usually give IM, but IV is also a route, right? We can give, right? Gabapentin is not an option in acute pain, right? Discuss this now. Cross these things. So do we use IV? Yes, IV paracetamol. Yes, we use. It's a good drug. And yes, regarding post-operative pain, what is pain? Do you know the definition of the pain? IM morphine is better than subcut. Usually we use subcut, but there's then we give IM off. But it's also a route, right? It's a recognized route, right? Absorption rates I'm not familiar, right? But you can give. You should read about these pharmacokinetics to compare the routes. I'll let you know later, right? What is IMO subcut? Usually what we use to give subcut, IM should be more effective because blood supply is more to the muscles, right? Post-surgical pain with regard to pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, right? That is the definition. It's an unpleasant sensory and emotional experience, right? Associated with actual or potential tissue damage. Pain can be categorized according to the duration, acute or chronic, according to the site of the origin, somatic or visceral pain, according to the etiology, nociceptive or neuropathic, right? Post-surgical pain, usually acute pain, right? And it has effects on almost all systems of the body, right? And you should know how to assess the severity of the pain, right? There are numerous scales and management. We follow the WHO analgesic ladder. Non-opioid analgesics, weak opioids and strong opioids, right? Right. Adjunctive options are these gabapentin, lignocaine. These are usually used. This gabapentin you use for usually for chronic pain, not usually in the post-op acute period, right? And local region anesthesia is also a good option, right? This plexus blocks, paravertebral blocks, epidurals also improves the post-op pain complications, right? Chronic pain, pain following a surgical procedure that lasts at least 2 months, right? And to diagnose post-surgical chronic pain, other causes for the pain should be excluded, like malignancy, infection, or pre-operative pre-existing pain, which arises due to another pathology, right? These mastectomies, amputations, thoracotomy, cholecystectomy, and hernia surgery are associated with most of the chronic pain syndromes, right? Okay, right. That's about pain management, right? Right. We took oral gabapentin as a false answer because acceptable pain management options, this is just 8 hours after the surgery, right? So it's not going to, it's a second line treatment, but you can't get much from, so in patients with respiratory problems, can we use morphine? Yes, respiratory depression is a complication of opioids, but it's not an absolute contraindication, right? You should outweigh the risk versus benefit, right? Even with COPD patients, we tend to give when there's a higher dose, no, till you reach the toxic level. So there's a good therapeutic window in morphine. You can use safely. You should monitor, and you should look for the complications. Careful monitoring as same as correct dose. Right. All right. Then okay. This is regarding peptic ulcer disease. Occurs more commonly in the antrum than the body of the stomach. What is the answer for this? Can you answer this? That's true, right? It's mainly antrum and the antral part of the stomach, pylorus, and the body duodenum. Unlikely to recur. No, it's it recurs, right? It's more likely to recur. So relapsing disease. It's a cause of microcytic anemia, yes, microcytic hypochromic anemia, because these ulcers tend to bleed. Invasion of pre-pyloric vein leads to massive hemorrhage. Usually, that is this massive hemorrhage is due to invasion of gastroduodenal artery. That lies posterior to the duodenum, first part of the duodenum. Anterior ulcers leads to perforation and peritonitis, right? Complications such as anterior ulcers leads to perforation. Posterior ones are the ones which lead to bleeding due to invasion of the gastroduodenal artery. Right? And can occur in Meckel's diverticulum. Yes, because Meckel's diverticulum carries the gastric epithelium, and it's a place of peptic ulcer development, right? Peptic ulcer disease only occurs when there's a gastric acid excessive production, right? And in hypo and achlorodic states, no peptic ulcer formation. Peptic ulceration due to excessive gastric acid production. Right? And common sites are D1 and lesser curvature of the stomach towards the antral side. Other less common sites are the on the stomas following gastric surgery, esophagus, Meckel's diverticulum. Right? Ulcers occurs at the junction between different epithelial types, where also occurs the epithelium least resistant to acid damage. Then the causes and risk factors: H. pylori, NSAIDs, cigarette smoking, and Solling-Gleason syndrome, where you have gastrinomas and very high levels of acid. Let's see, right? Give me a minute, right? Okay. Okay. Right. Can you all hear me now? Hello? Can you all hear me? All right, okay. Then this peptic ulcer disease most commonly occurs in the antrum, yes, and the duodenum. It recurs, it's a cause of microcytic anemia. It invades the gastroduodenal artery, not the prepyloric vein. It lies anterior. Right, and we went through the article. Duodenal ulcers, right? Peptic ulcers consist of duodenal and gastric ulcers, right? These duodenal ulcers are commoner than gastric ulcers when it comes to peptic ulcer disease. To the muscle cord and leads to fibrosis and stenosis, right? Anterior ulcers tend to perforate, posterior ulcers tend to erode the gastroduodenal artery and bleed, right? Gastric ulcers, those gastric ulcers tend to be large, right? Fibrosis can lead to hourglass contraction of the stomach. Large posterior ulcers can erode to pancreas or splenic artery, or less commonly to transverse colon. Right? There's a high association with malignancy, so you should take biopsies in gastric ulcers, right? That's that. Then, right, if you know if you can remember the anatomy, this is the sides of the stomach, right? Cardia, fundus, then the body, pyloric antrum, and the pyloric canal, then comes the duodenum. So, this peptic ulcers occurs in the duodenum and the along the blister curvature border, mainly in the pyloric antrum, right? This region. Lesser curvature border of the pyloric antral part and the duodenum. That is where you see the peptic ulcers common. Then, what else? Yeah, those are the basic stuff. Comes to this question. Question number 4. A 45-year-old woman presenting with 2 weeks history of increased frequency of bowel motion, abdominal pain, PR bleeding, and she is diagnosed patient with ulcerative colitis. True or false regarding this exacerbation? It's a relapse of the ulcerative colitis, right? Can be managed as an outpatient with this abdominal pain, PR bleeding, right? Increased bowel motion. Looks like a severe episode, so you can't manage as an outpatient, right? It's false. Need urgent laparoscopy. It's false. This history doesn't give a history. History doesn't suggest of this bowel perforation or peritonism, right? So there's no indication for laparotomy as for now. Needs immediate colonoscopy. False, because you have a diagnosis, confirmed diagnosis, and there's a history more suggestive of a relapse. So you don't have indication for immediate colonoscopy, right? Response to steroid therapy, yes. It makes the remission. We give steroids to achieve a remission, right? Then maintenance by sulfasalazine or metolazine. Sulfasalazine is effective as an initial treatment. Yes, true. Inflammatory bowel disease, there are 2 main types, right? When it comes to inflammatory bowel disease, ulcerative colitis and Crohn's, 2 arms are there, right? Ulcerative colitis usually confined to the epithelium, mainly arises from the rectum and ascends and involves the rectum and the large bowel. But Crohn's, it affects the entire thickness of the gut wall, and it can affect from mouth to anus, anywhere of the GI tract, right? Sulfasalazine, is it for initial treatment or for maintenance? Sulfasalazine, yes, mainly for the maintenance, but it induces the relapses as well. It induces a remission as well, right? We'll go to the treatment, then comes to this point. Yeah, it's a good question. Sulfasalazine, it induces remissions as well, right? So it is a drug we give in initial period. As treatment. Yes, management of Crohn's and ulcerative colitis, conservative measures, smoking. You should counsel the patient to stop smoking, right? Smoking is protective in ulcerative colitis and it deteriorates in Crohn's, but overall, when you consider the overall benefits, it's better to stop smoking, right? Both the arms. The diet, then the proper education, medical management, is mesalazine and sulfasalazine, right? It induces and maintains the remission in mild to moderate diseases, right? It is protective against colorectal carcinoma and ulcerative colitis. So it is a drug you use in initial period, and you give steroid to get the remission, but you start the sulfasalazine as well at the same time. Okay, a little bit about ulcerative colitis. The basic differences is distribution. Crohn's involves from mouth to anus. Ulcerative colitis, it mainly affects rectum and the colon, right? And depth of the disease, Crohn's, it involves entire thickness of the colon, gut wall, but in ulcerative colitis, it's only superficial inflammation of the mucosa, right? And in ulcerative colitis, it usually arises in the rectum and ascends, and there's a continuous involvement. In Crohn's, it's a patchy involvement, right? Ulcerative colitis, a disease is limited to the mucosal layer of the colon. Starts as ulcerative proctitis, then ascends. Then it becomes proctosigmoiditis. Then involves the left colon. In extensive disease, it affects the entire colon up to the cecum, right? If the cecum is involved, it's called pancreatitis. Right. Then clinical features, diarrhea, PR bleeding, frequency and urgency of defecation, and there are extra-intestinal manifestations. Complications, acute complications are severe bleeding, fulminant colitis, and perforation. In this patient, they were given the enough details to assess the severity of bleeding, but there are no evidence of perforation, right? And chronic complications are strictures, dysplasia, and risk of colorectal carcinoma. Right. That's that, right? Ulcerative colitis. You should know about these two arms of inflammatory bowel disease. That will be a topic in your MCQs and long cases as well, right? Okay. Then you don't already the inflamed bowels are unhealthy, more tendency for perforation. Unless there's a real absolute indication, no point of doing a colonoscopy, right? Because you have a diagnosis and you know the scenario, there's no place for urgent colonoscopy. And unless there's a bowel perforation, no indication for surgical intervention as well. Right. Then incisional hernia. Regarding incisional hernia, rectus, what is an incisional hernia? What is the definition of incisional hernia? It's a herniation through a weakened surgical scar, right? That is what happens in incisional hernia. You do a surgery, and this either patient-related factors or surgery-related factors, this incision is going to be healed with a weakened scar. So abdominal contents will tend to protrude through this weakened scar, and it becomes a hernia, right? That is the clinical picture of incisional hernia. So risk factors which give rise to incisional hernia. Patient-related factors: if the patient is severely obese and immunocompromised, nutrition deprived when you perform the surgery, right? If there's a post-operative infection in surgical site, those factors will lead to poor healing of the surgical scar, surgical incision. Poor healing will lead to weakened scar. If you don't follow the proper technique of suturing, right? If there's a gross contamination of the surgical site due to bowel perforation, so those factors will lead to post-operative infection, and that will impair the wound healing, and your incision will be defectively healed and scar will be weaker. From there, you get this herniation, right? That is that. Rectus closure with absorbable sutures reduces the risk. Usually, you should suture this fascias, rectus sheath, anterior and posterior layer with non-absorbable sutures, right? You don't suture absorber. You don't suture with absorbable suture materials, because absorbable suture materials only retain the tensile strength for 2 weeks. Thereafter, they will degrade and tensile strength will be diminished, right? To get the complete wound healing process, it takes about 3 months, right? Even after 3 months, and if the patient gets a proper wound healing, strength of the scar will be 80% of the normal strength of the body tissues, right? You don't get the normal strength from a surgical scar. It's only the 80% of normal strength of the body wall. And if the wound healing process becomes impaired or defective, so the tensile strength will be further reduced, right? And usually you use non-absorbable sutures or suture materials like PDS. Those are absorbed but it remains in the body for 2-3 months with maintaining tensile strength. Higher rate of strangulation than femoral hernia. No. This usually incision hernia, there's a surgical incision, no, weakened surgical scar. So the neck will be larger. In the femoral hernia, this hernias tend to get obstructed and strangulated because neck is narrow. Incision hernia, it's not like that. Usually this neck of the hernias are larger. So When you compare femoral hernia, strangulation risk is lower in incisional hernia. Prophylactic mesh reduces its risk. No, putting prophylactic mesh doesn't reduces the risk of incisional hernia. If you follow the proper technique of suturing, and if you optimize the wound healing factors, systemic and local factors, that will reduces the risk of incisional hernia. Putting a mesh wound reduces the risk of incisional hernia, right? Obesity increases the incidence. Yes, obesity will lead to stretched fascias. It will lead to difficult exposure, and performing surgery will be difficult in obese patient, right? Tissue handling, suturing, everything will be difficult. So risk of incisional hernia is higher in obese patients. Right. Hernias. Little bit of hernia. Hernia is a bulging of part of the contents within the abdominal cavity, right? Through a weakness in the abdominal wall. Which hernia is the least likely to cause strangulation? Is it incisional hernia or direct inguinal hernia? You can't. There's a question. Which hernia is the least likely to cause strangulation? Is it incisional hernia or direct inguinal hernia? In direct inguinal hernia also, this hernia, neck of the hernia is large, right? Direct inguinal hernia, contents protrude through the posterior inguinal, posterior wall of the inguinal canal. So the neck is large. In this incisional hernia also, most of the time this neck is larger, defect is larger, so the hernia, neck of the hernia is larger. So you can't just compare both of them. You can say strangulation risk is reducing both the hernias. Did you encounter such a question? It was best of 5 questions. What are the other 3? What was the question? If you give me a question, you give me the question and the answers, I'll give you the answer. What was the question? You can't just compare the strangulation risk in incisional hernia and the inguinal hernia, right? It's a postgraduate question if you have been asked, because you should do a correct study and prefer evidences to answer such a question. Causes of hernia. It can be natural weakness of the wall due to inadequacy of muscle strength, like in lumbar hernias, weakness of the lumbar triangle. And direct inguinal hernias, posterior wall of the inguinal canal becomes weaker, right? Those are natural process of weakening due to aging and poor nutrition, different stuff. And it can arise due to natural weakness of the orifices. This natural orifices that in condition, natural weakness due to structures entering and leaving the abdomen. Naturally, that means if consider indirect inguinal hernia, you have a deep inguinal ring, right? If it gets wider or weaker, contents protrude through that opening. It's a natural opening, becomes weaker and leads to herniation, leads to hernia, formation of hernia, right? In esophageal hiatus, right? In the if it gets wider and weaker, that will lead to hiatus hernia. Femoral canal, again, if it is get wider and due to the hormone effects, estrogen, if these ligaments get relaxes, that will leads to femoral hernia. And sciatic foramen, again, confined with ligaments. If those ligaments are weaker and softer, leads to sciatic hernia. Umbilical hernia arises from the orifice which allows the umbilical vessels, passing of umbilical vessels. Right? Again, congenital hernias arises due to development failures. Patent process vaginalis, this gastroschisis, right? Those are due to developmental failures. Right. Then essential components of the hernias, there should be defect, and sac consists of fundus, body, and the neck, and within the sac there are contents, right? Those bits will be enough for now. We'll move to the next question. Right. Regarding the neoplasm of the liver, right? Hepatic neoplasms. Hepatic adenoma is a complication of prolonged OCP. That's true. Yes. Cirrhosis is a risk factor for hepatocellular carcinoma. Yes, always hepatocellular carcinoma arises in a cirrhotic liver. Background liver will be cirrhotic. Metastatic colorectal cancer can be cured completely by resection. Yes, if the metastatic part is confined to a resectable part of the liver, if you take that part out, that is curable, right? Commonest is the hemangioma. Yes, benign. Most commonest benign lesion of the liver is hemangioma. Transplantation is it curative treatment for hepatocellular carcinoma? Hepatocellular carcinoma, if this hepatocellular carcinoma is it resectable, and there are indications for transplantation, right? Each and every hepatocellular carcinoma, you can't do the transplantation, right? If these features of carcinoma, if it is not a multifocal disease, unifocal disease, without involvement of IVC, if it is resectable completely, a stage is, if it is a local disease without metastasis, then you can resect the liver and do the transplantation, and it will be curative. Right? Regarding liver lesions, classification of the liver lesions. It can be solid, cystic, or abscesses, right? Solid lesions can arise from epithelium. If it is epithelial, it can be hepatocellular or biliary, right? And it can arise from vascular structures as well. Benign hemangioma, malignant angiosarcoma, or it can be miscellaneous hepatic lymphomas and angiolipomas. The hepatocellular carcinomas, hepatocellular neoplasms, benign conditions are focal nodular hyperplasia, hepatocellular adenoma. Malignant epithelial lesions, solid tumors, primary, it can be either primary or secondary. Primary tumors will be hepatocellular carcinoma, fibrocellular carcinoma, and hepatoblastoma. Or it can be secondary lesion due to metastasis, right? And vascular and miscellaneous we went through. Those are solid liver lesions. Liver cyst can be hydatid cyst, simple liver cyst, polycystic liver lesions, or cystadenomas. And abscesses can be amoebic abscess or pyogenic abscess, right? Those are the main classification of the liver lesions. And hemangiomas are the commonest benign lesion, right? Mostly asymptomatic, you find as an incidental finding, right? And mainly conservative, you manage conservative. Hepatocellular adenomas are rare benign neoplasm, common in women, strongly associated with OCP, right? Low but significant risk of malignant transformation as well. That is with regard to hepatomas, right? Hepatic adenomas. Then there are benign biliary tumors as well, bile duct adenomas, hematomas, the liver cyst, hydrated cyst, and simple cyst of the liver. Polycystic liver lesions can be associated with polycystic kidney disease. Then the liver abscesses, pyrogenic abscesses can be hematogenous. Abscess can be due to infection somewhere else, right? Then amoebic abscess, right? Due to histolytica infection. Right. Those are question 6 answers. Hepatic carcinoma is a complication of prolonged abuse. That's true. Cirrhosis is a risk factor for hepatocellular carcinoma. Again, it's true. Metastatic colorectal cancer can be cured complete by resection. Yes, that's also true. Commonest benign neoplasm is hemangioma. Transplantation is curative if the other features are fit for hepatic resection, transplantation. Right? Hepatocellular carcinoma. Risk factors. This hepatocellular carcinoma can arise with cirrhosis or without cirrhosis, right? With cirrhosis, there are viral causes, hepatitis B and C infection. Non-viral causes, alcoholic cirrhosis, NASH, hereditary hemochromatosis, porphyria acute tarda, this Wilson disease, primary biliary and alpha toxins. So many causes. And AFP you use as a alpha fetoprotein used as a tumor marker in screening, right? You should do ultrasound scan. If there's a doubt, go for CT, right? Triphasic CTs. If you know that bit, that will be enough. Usually you diagnose by imaging. If there's a really doubt, you go for biopsy, right? Otherwise, CT findings will be enough to diagnose hepatocellular carcinoma, such as your renal cell carcinoma and pancreatic tumors, right? You diagnose by imaging, mainly CT findings. Then, regarding chronic pancreatitis, yes. What is chronic pancreatitis? There's a chronic inflammatory process in the pancreas, right? There is a tissue damage and healing process occurs at the same time, right? Splenic artery thrombosis is a complication. Usually, splenic artery gets aneurysms and splenic vein gets thrombosed, right? So it's false. Gallstone are the commonest causative factor in Sri Lanka. It's alcohol in Sri Lanka, etc., right? Should give rise to chronic pancreatitis. Intraductal calcification can be seen on abdomen X-rays. Yes, there will be dystrophic calcification. Hypoglycemia is a feature. Yes, this during endocrine failure you get hyperglycemia. At the same time, this in chronic pancreatitis, you get this your glycogen secreting cells will also get disrupted. So you can get hypoglycemia as well, right? Chronic pancreatitis is a continuous prolonged inflammatory process of the pancreas with irreversible morphological changes. Oh, there will be fibrosis, stricture formation, and there will be pancreatic exocrine and endocrine failure due to extensive destruction of pancreatic parenchyma, right? And pathophysiology, there are 4 theories. Difference between acute and chronic pancreatitis. Acute pancreatitis is an acute inflammatory process and which is non-progressive, right? And recurrent episodes of acute pancreatitis can lead to chronic pancreatitis all the time. Right? Major differences: chronic pancreatitis may be asymptomatic over a long period of time. But acute pancreatitis is always symptomatic. Serum amylase and lipase levels are normal in chronic pancreatitis. But in acute pancreatitis, those are elevated. Morphologically, chronic pancreatitis is a patchy focal disease, right? But in acute pancreatitis, diffuse involves a large portion of the entire pancreas. So in stem B, if they don't say in Sri Lanka, it would be. As in Western countries, gallstone disease is the commonest cause for pancreatitis. Yes. And chronic pancreatitis causes severe pain due to increased intraductal pressure, parenchymal edema, and neuronal inflammatory mediators. And if there's a then chronic pancreatitis is a risk factor for pancreatic CA, because if there's a ongoing chronic inflammation in any tissue compartment, it's a risk factor for development of malignancy. Right? So if they develop malignancy in chronic pancreatic picture, they get severe pain. Right? Etiology, alcohol, idiopathic genetic component is there as well, autoimmune, recurrent severe acute pancreatitis, and obstruction of the duct. There are rare causes for chronic pancreatitis as well. Clinical manifestation, mainly abdominal pain and pancreatic insufficiency. Right? And there will be features of complications as well. Right? Abdominal pain, there's a deep, boring, mild to severe pain radiating to the back, relieved by leaning forwards, right? And there will be a exocrine and endocrine insufficiency. Exocrine insufficiency leads to steatoria or azoturia due to chronic protein malabsorption. Endocrine insufficiency leads to pancreatic diabetes, right? Clinical manifestations of complications, there can be pseudocyst formation, bile duct or urinary obstruction, pancreatic ascites or pleural effusion, splenic vein thrombosis, pseudoaneurysm, and pancreatic cancer. Classic trial to clinch the diagnosis, classification, steatoria and diabetes, right? Trial to clinch the diagnosis is not seen often until the late, very advanced. In the advanced setup, you will see this trial, classifications of the pancreas, steatoria and diabetes, right? And if you do a abdomen X-ray, you will see these calcifications clear in pancreatitis, chronic pancreatitis, right? Right. Regarding breast carcinoma, ductal carcinoma NC2 is pre-invasive. Yes, as its name implies, it's not invaded. Positive receptor status is a poor prognostic factor. ERPR positive is a good prognostic factor, right? And HER2 positivity is also now there are targeted therapy, so it's false. Improved survival in breast cancer is mainly due to advancement in surgical techniques. Not really due to surgical techniques, that is due to screening and target therapies. The screening has been improved due to these mammograms, right? And there is a targeted therapy. You target the growth factor receptors ERPR and HER2, and that has clear advantage over previous treatment regime, and it has led to improved survival. It is the commonest cancer in Sri Lanka. Yes, breast carcinoma is the commonest carcinoma. Commonest carcinoma among males will be oropharyngeal CA. Right? And this lung carcinoma is the, I think, that carries the biggest mortality. Prognosis is better in postmenopausal women. That is a tricky question, right? Is when you get a breast in younger patient, that will be more aggressive because it's most of the time when you get a breast cancer in early ages, there should be genetic component as well, BRCA1, BRCA2 positivity, familial inheritance, and all these factors lead to breast CA, which occurs in early stages of life. But when it comes to old age, breast carcinoma persists will be less aggressive. But this fitness for surgery, fitness for chemo, radiotherapy, and the post-operative recovery all will be impaired when you get old. So it's a bit of a tricky question. Actually, I couldn't find clear evidences to mark it as true. If you all have any answers to this, 8E, what is your answer? What are your answers? Prognosis better in postmenopausal women. Can take it as in both ways. What are your answers? There was a question. Is there a timeline between chronic and acute pancreatitis, like 3 months of chronic inflammation and acute inflammation? If you read that, if you know that part, you can answer this, right? In the chronic inflammation, there will be tissue destruction, and at the same time, there is a tissue repair. The tissue tries to repair itself, right? So the fibrosis, calcification, all things can be seen at the background of tissue damage. That is what we call chronic inflammation. In chronic pancreatitis, there's a chronic inflammation. In acute pancreatitis, there's only acute inflammation, right? There are no features suggestive of tissue repair. There's no clear timeline for that. That is pathological definition, right? Pathological definitions. Yes, 8E, I'll leave, right? No answer for me. There are facts for and against. Better leave it out. If I find answer, I'll let you know, right? Then 25, now question number 9. 25-year-old woman underwent total thyroidectomy, presented to the ward 3 days after the surgery with carpopedal spasms. It's post-operative hypocalcemia following thyroidectomy, right? Which of the following are true? Commonest cause is accidental removal of parathyroid. Commonest cause is ischemia of the parathyroid, not the removal, right? Correction of magnesium is indicated in this patient. No, it's false. Correction of calcium. What you should do. Parathyroid hormone level should be assessed before the treatment. No, it's false. These are emergency, right? Carpopedal spasms. Patient comes with carpopedal spasms means severe hypocalcemia. They can develop upper airway obstruction due to laryngospasm. So you should correct the hypocalcemia then and there. You can't wait for investigation to confirm your diagnosis. Treatment with oral calcium is sufficient in this instance. No, you should give IV calcium gluconate, right? Should act early. You should give IV calcium gluconate 10%, IV calcium gluconate 10 ml or 10 minutes, right? Recovery occurs within 6 months. Yes, if it is ischemia of the parathyroids. There's a question 8D. Can't mark 8D. Status commonest carcinoma in Sri Lanka, it will be oral. Commonest cancer, breast CA, commonest cancer among males will be oral cancer, no? Who says oral cancer is commonest cancer? Your evidences. 30 ml of that's 10 ml of 10% calcium for 10 minutes. Kiri Baba. Recovery, if it is if this hypercalcemia due to parathyroid ischemia, that will recover after 6 months, usually within 6 months, right? Right. Then question number 10. In a 50-year-old male presenting with large parotid tube, xylogram is indicated to exclude calculus. No. Xylogram, if you go into 10% 10 ml calcium chloride or 10% 30 ml calcium chloride. Same, no? Why 30 ml? Usually 10 ml. That is the dose. If they don't respond, you can repeat, right? You can't exclude calculus by taking you an X-ray or doing ultrasound scan. Xylogram is not. You don't have to do xylogram always. If you intervene, if you suspect stone within the duct, if you going to intervene, then you can do xylogram. Co-biopsy is mandated. No. We usually do FNAC. We don't do co-biopsy because it can damage the facial nerve. At the same time, it can lead to bleeding, right? Usually we do FNAC, right? So co-biopsy is not mandatory at all. Lateral facial nerve pulse is a feature of compression. It's feature of malignancy. If the tumor is malignant and if it is invaded the facial nerve, they will develop facial nerve pulse. Right? In benign neoplasms, you don't get facial nerve pulse. Right? It's mainly a feature of malignant invasion, not due to compression. Pleomorphic adenoma will be the most likely. Yes, in parotid tumors, 80% of salivary gland tumors arise in parotid gland. And in parotid tumors, 80% are pleomorphic adenomas, right? 80% are benign. Out of these benign tumors, 80% are adenomas. 80% of the salivary gland tumors arise in the parotid. And in the parotid tumors, 80% are benign. From those benign tumors, 80% are pleomorphic adenomas. Ultrasound scan is indicated, yes, that is the basic imaging you do. 9E. 9E, answer true. We did chronic pancreatitis, we did. Then this acute pancreatitis. Carcinoma, did salivary gland tumors. Evaluation of the parotid tumors, right? Salivary glands, mainly parotid, submandibular, sublingual. 80% of tumors are parotid. 80% of parotid, 80% of that will be pleomorphic adenomas, right? In submandibular tumors, 50% will be malignant. Okay. Out of tumors in minor salivary glands, 80% will be malignant, right? Risk factors are radiation, smoking, Worthin tumor of the parotid, usually it is smoking, viral tumors, chemicals. Right? So presentation, major salivary gland tumors, painless mass. If pain, there will be perineural invasion, phlegmatic pain, and facial nerve palsy. That is most of the malignancy. Right? Minor salivary glands, nasal congestion, trismus means difficulty in opening mouth, and painless submucosal mass or mucosal ulceration. And they can present as lymphadenopathy as well, right? Benign tumors, pleomorphic adenomas, Worthin's tumor, monomorphic adenomas. Malignant Mucoepidermoid carcinoma, adenoid cystic carcinoma, or it can be metastatic tumors as well, right? Melanomas, squamous cell carcinomas, or breast C. Its secondary is in parotid, right? Pleomorphic adenoma is the most common tumor of salivary gland, most frequently found in parotid, slow growing, painless tumor, and mixed in origin. Worthin's tumor, second most common, benign neoplasm, exclusively occurs in parotid, associated with smoking, right? Then, evaluation, first line imaging is ultrasound scan, guided FNAC to distinguish distinction between neoplastic and non-neoplastic, right? Why not biopsy? Hematoma risk, damage to nerve, fibrosis can alter the anatomy, and preserving the nerve during surgery will be difficult, right? That is the reason you avoid the biopsy in parotids. If you do a biopsy, that will lead to healing. You take a tissue part, there will be fibrosis, and during surgery, it will be difficult to identify tissue planes and preserve the nerve, right? Treatment, surgical excision, and depends on the lymph node status, lymph node clearance, right? Then that's regarding parotid tumors. Chest injuries that respond well to mechanical ventilation. Cardiac tamponade, there will be blood in the pericardial space. So unless you decompress, you can't achieve anything, right? That is a obstructive shock. Due to compression of that cardiac tamponade will prevent the relaxation during diastole, right? It will lead to reduced cardiac output. So you should do, if it is traumatic cardiac tamponade, definitive treatment is thoracotomy and take the blood out in the pericardial space and arrest the bleeding, right? If there's a injury in the heart, you should repair it. Flail chest, yes, it's a condition where mechanical ventilation is a good option, right? There's a isolated part due to flail chest means two or more fractures gets fractured in two positions, and there is a independent part of the chest wall which moves paradoxically. That moves paradoxically when you compare the rest of the chest wall. When the rest of the chest wall moves outwards, it goes in. It goes outwards, and the rest of the chest wall relaxes, right? So if you intubate and ventilate, patient will definitely respond. Most of the time, only thing you need is the pain relief. But if the patient is hypoxic, you should intubate and ventilate, and patient will respond. To reduce the duration of the ICU stay or ventilation, you can fix the flail segment, right? And open pneumothorax, you should do the thoracostomy. An IC tube insertion is the treatment. Otherwise, ventilation won't get too much, right? Pulmonary contusion, again, respond well to mechanical ventilation. Tension pneumothorax, again, you should decompress by putting IC tube, right? So, A false, B true, C false, D true, E false, right? Those are things. Regarding abdominal trauma, damage control surgery can reduce the irreversible physiological insult. Yes, that is the idea of damage control surgery. Bleeding, and if there's a contamination, you should get rid of the contamination, then get the patient's physiological parameters back to normal, then do the definitive surgery. That is the idea of damage control surgery in trauma, right? You prevent the second insult due to surgery. because surgery itself carries a degree of trauma that will worsen the physiological delay in already dealing patient was undergone trauma, right? Interventional radiologists can be involved in achieving hemostasis just when it comes to this, renal injuries relative to laparotomy in stable patients. In trauma setup, laparoscopy is out, right? Because it takes longer duration, right? You don't do laparoscopic surgeries in trauma setup, right? Can you all hear me? Okay. Well, damage control surgery we discussed, no? You heard that part, no? Right. Interventional radiologists can be involved in achieving hemostasis, yes. Laparoscopy is an alternative laparotomy in stable patient. No, in abdominal trauma setup, laparoscopy is out, right? It takes longer time. We don't usually practice even in stable patients. Surgical intervention is mandatory for liver resection. No, not the liver injuries. It's not mandatory. Sometimes you go for conservative management as well, right? Observing, right? You don't always do surgical interventions, right? It's not liver resection, liver injury. It's a printing error. You can't see the screen. Okay. Sure. Now can you see? Okay, right. Then, regarding acute osteomyelitis in children, commonly lead to chronic osteomyelitis. That's false. Most common side is metaphysis. Yes, true. Treatment with parenteral antibiotics. Yes. IV antibiotics should be given. Most common organism is Staph aureus. Yes, that is skin flora. Surgical intervention is treatment of choice. That's false. Usually managed with antibiotics. If it doesn't respond to antibiotics, then you plan for the surgical intervention, right? Nichols diet. This is incisional hernia classification definition in the up-to-date. Any abdominal gap with or without a bulge in the area of post-operative scar. Positral palpebral clinical examination. Right? Then what is this? Yes, osteomyelitis. Osteomyelitis in children, right? Incidence of pediatric osteomyelitis varies geographically and greater in Europe and Europe countries. Risk factors: Neonates include complicated delivery, premature skin infection, pathogenesis of hematogenous osteomyelitis involves deposition of bacteria in the metaphysis into cellular areas of the bone marrow. Spread of infection is influenced by characteristics of the growing skeleton. The young infant, the thin cortex and loosely applied periosteum are poorly able to contain infection. And in the young infection, there's a risk of septic arthritis as well, right? Most causes of acute hematogenous osteomyelitis are caused by single organism. Right? Staph 4 is the most common cause of osteomyelitis. The other things. Focus of the infection in the metaphysis lead to cellular disease in the bone marrow, right? Inflammatory exudate in the marrow causes increased intramedullary pressure, which forces the exudate through the Haversian system and Walkman canals into the cortex, where it can rupture through the periosteum. That is what happens, right? There was a diagram, I can't find it. This is epiphysis, this is their metaphysis, right? That is the region where you get this osteomyelitis in children, right? And that is how it really comes to the periosteum, and there will be periosteal elevation, right? And Staph aureus is a common organism. What else? And surgical intervention, no? I think it's surgical intervention, no? Pathogenesis. What is this? Management. Indication of surgery. Surgical intervention may be required at the time of presentation or during antimicrobial therapy if the children fail to respond as expected, or MRI indicates extensive bone or soft tissue involvement, right? Otherwise, you can manage by IV antibiotics, right? In patients suspect septic arthritis, what do we do first? Blood culture, joint freedom. Septic arthritis, it's a clinical diagnosis. You should do the arthrotomy, urgent arthrotomy. Then you open into the joint, and then you take the pus and everything for the culture, right? That's what you do in septic arthritis. There's a question in patients suspected septic arthritis. What do we do first? Blood culture, joint fluid aspiration, or some. Take cultures, yes, blood cultures. Then urgent arthrotomy is the definitive treatment, right? Okay. Okay, you've commonly lead to chronic question, that's false. Unless you neglected the case, it settles, right? Joint fluid aspiration, no point of doing, no, you anyway going to open, right? Yeah, before starting antibiotics, Yes, you can do the aspiration, but if it is a septic arthritis, you don't just do the aspiration and wait. You should do the arthrodome, right? Right. Before starting antibiotics, you should take samples. Yes. Most common site is metaphysis through treatment with parenteral antibiotics. Most common organism is Staph aureus. Surgical intervention is not the treatment of choice. If they don't respond to antibiotics, or if this infection is very severe, then you go for the surgical debridement. Right? Okay. Then 65-year-old patient present with acute retention, acute urinary retention, and after catheterization, 2 liters of volume urine was drained by catheter. What is the management relevant for next 48 hours? Yes, acute urinary retention due to lower urinary tract obstruction, right? And there's a painful inability to pass urine, and on examination there will be tender palpable bladder. That's what happened in acute urinary retention, and it's due to lower urinary tract obstruction, either from the bladder of the neck, due to prostatomegaly, benign or malignant prostate, or urethral strictures or stone infection, or maybe for any reason there is obstruction. So you get a palpable, painful. So this is acute or chronic. This is an acute retention, but the volume is a bit larger, no? In the history, they say acute retention, but usually this much of volume you expect in this chronic retention, but rarely you can get no large volumes. Less than 100, this volume is, you can't always go by the volume, right? Usually they say less than 1 liter for acute, more than 1 liter, more towards the chronic, but it's a clinical presentation. Right? There maybe this, probably they are mistaken when they collect the question. It's maybe printing error. This volume is a bit misleading, but how you diagnose acute versus chronic with retention comes from the clinical picture. In acute retention, this painful inability to pass urine on examination, there's a palpable tender bladder, painful bladder, tender bladder, right? In chronic retention, even after voiding, there will be palpable bladder, and this bladder won't be tender, right? And there are 2 categories in chronic retention: high pressure and low pressure retentions. In high pressure retentions, you get this renal impairment, right? Due to high pressure. 13 STEM C and D answers. 13 C and D. C true, D true. Right? With regard to this patient's management, serum creatinine, yes, you should do the renal functions and acute setup. Prostatectomy is not indicated in acute setup, right? You manage the retention, then evaluate, right? PSA levels, again, not in the acute setup. After catheterization and DRA, you get this high PSA levels. So it's, you should wait till the acute episode settles out. After 2-3 weeks, you should do the PS, right? Not in the acute setting. Tamsulosin therapy, yes. If it is a prostatomegaly, if you suspect BPH, yes, you should start tamsulosin and finasteride, file for reductase as well. Considering the age, it is a BPH. Then you start medical therapy, catheterize, then try to do trial without catheter in about 5 to 7 days. Right? Then evaluate with ultrasound scan, pre and post voidal volume. If it is malignant looking, you plan for transrectal ultrasound guided biopsy. Right? We can't see your notes. Yes, I haven't. Okay, I haven't opened now. Wait. Acute retention. Acute. So, yes, lower urinary tract obstruction. Could be bladder, neck, prostate, or any point along the urethra, right? Can be acute or chronic. Is acute retention, sudden painful inability to void that results in painful distension of bladder. That is the definition. 3 cardinal features: never to pass urine despite having a strong desire, low abdominal pain, tender palpable bladder. Right? There are obstructive myogenic or neurological causes. Obstructive mechanical BPH or urethral structures. Dynamic causes can be due to post-operative pain, drugs, or prostatic inflammation. There are myogenic causes. According to etiology, up to 15 years, it's due to UTI or constipation, acute urinary retention. 15 to 50 years, it can be due to bladder, neck, stone, urethral stricture, neurological causes. Above 50, benign or malignant prostatic enlargement, usually, right? Risk factors for acute urinary retention BPH: age, previous history, severe large hypoplastic prostate. Right? And high PSA values, increased post-voidal volumes, reduced maximum flow rate, all are risk factors for retention. This is your classification. If it is 1 liter, acute retention. If it is more than 1 liter, acute and chronic, right? Trial without catheter is likely to fail if the initial volume is more than 1 liter. Right? Then, why is this? Management, decompression, then go according to the etiology, right? Alpha blockers, fire reductase inhibitors, then trial without catheter. Usually 3 to 5 days, you let the drugs to act, alpha blockers and the fire reductase. Wait for 3 to 5 days, then remove the catheter, right? That is how you do trial without catheter. Then you do the assessment. Assess the prostate, whether there is benign or malignant, pre and post volume. Do the PSA values, right? Then go according to findings, right? If the patient fails with trial without catheter, it's an indication for TUR, transurethral resection of prostate. This is chronic retention, unpainful bladder that remains palpable even after voiding, right? This high pressure and low pressure thing, high pressure, voiding dead tooth pressure is high, right? Urine flow rate is low, very large residual volume is there, storage residual pressure is high, right? As bladder pressure is constantly high, there will be backward pressure on the upper tract and there will be bilateral hydronephrosis and renal failure. Low pressure retention, chronic low urinary tract obstruction leads to change within the bladder, trabeculations and divertical formation, bladder wall thickening, and eventually dead tooth decompensation. Right? There will be a decompensated detrusor muscles, and its bladder detrusor muscles lose its elasticity, right? Bladder becomes very compliant, right? So the residual volume is very large than the high pressure. Since within the bladder pressure is low, so there won't be any backflow. So no hydrogen for renal failure. Someone has asked about this high pressure and low pressure thing. This is that, right? In chronic retention. Okay, coming back to the question. Serum creatinine is true. They're asking about management within next 48 hours. You should assess the renal function. Prostatectomy PS levels out. Tamsulosin again, yes. Trial without catheter again, not within the first 48 hours, right? Right. Regarding causes of renal cell carcinoma, chronic hemodialysis, yes. Nipple Linda syndrome, again, risk factor. Renal papillonecrosis, acidosis, all those are false, right? Where is this? Renal cell carcinoma. Etiology, smoking, obesity, hypertension, acquired cystic kidney disease, hemodialysis. So there's a 7-fold risk after 10 years of hemodialysis. Renal transplant, increased risk of renal cell carcinoma, negative kidney. Family history. Nipple Linda syndrome. Then again, there's a genetic parts, inherited papillary renal cell carcinoma, leiomyoma, talked about syndrome. Those are different things, right? Classic triad of presentation in renal cell carcinoma: flank pain, gross symmetry, and palpable abdominal mass. Right? And there will be features of paraneoplastic syndrome, and can be symptoms of metastasis as well, as for any malignancy. Bone pain, if there are lung mets, persisting cough, there are brain mets, early morning headache, and vomiting. Right. Coming back to our question, A and E are true, rest are false, right? 50-year-old retired school teacher with history of smoking for 20 years, presented with cough, claudication after walking 200 meters. On examination, there was an absent popliteal and pedal pulses. Right? There is an intermittent claudication. Claudication distance is 200 meters, right? History of smoker, that is a risk factor. And pulses are absent. Popliteal below. That means there's an obstruction. That means femoral should be palpable. So the obstruction should be below femoral. There, right? Most probably the obstruction in the superficial femoral artery. According to Fontaine classification, right? There are 4 stages. Stage 1 is asymptomatic. Stage 2, intermittent claudication. There are 2 categories, A and B. A is claudication distance more than 200. B is claudication distance less than 200. C is rest pain. Stage 3 is rest pain. Stage 4 is tissue loss. Right? There is a Fontaine classification of severity of peripheral vascular disease in the lower limb. Chronic lower limb ischemia, right? Risk factors, there are modifiable and non-modifiable risk factors. Chronic arterial stenosis, mainly the reason is atherosclerosis disease. right? It is a heavy smoke Burgess disease in athletic patients, popliteal artery entrapment syndrome. There are rare causes as well, right? Mainly the atherosclerosis. Limb ischemia is stage 3 and 4, or just stage 4. Critical limb ischemia means both the breast pain and tissue loss all together, right? Critical limb ischemia means the vascular supplies not adequate even to maintain the basal metabolic rate. They get breast pain and tissue loss as well. Both the categories are included in critical limb ischemia. Intermittent claudication is different. There is a vascular compromise. You get the ischemia only with exertion. At the rest, vascular supply is adequate, right? That is the thing. In the critical limb ischemia, even in the rest, without exertion, you get the pain because vascular supply is not adequate to maintain the basal metabolic rate as well, right? So that was your question, pretty Baba's question. Okay. Then this non-vascular causes, the chronic limb ischemia is a long case, right? Non-vascular causes that mimic chronic limb ischemia, osteoarthritis, degenerative spinal disease. Atherosclerosis can affect lower limb, brain, myocardium, kidney, anywhere else, right? Intestine. So if you have a patient with atherosclerosis in lower limb, you should suspect atherosclerotic disease in other parts of the body as well, right? That's why you asked in the history, past history of TIA, strokes, MIs, renal failure, this mesenteric anginas, right? Because you suspect atherosclerotic disease in other parts of the body as well. Intermittent claudications, what happens is there's a cramp-like pain felt in muscles that develops on exertion and relieved completely by rest. The pain is not present on the first step, right? It comes with exertion up to some degree and completely relieves with rest. Then it's reproducible, right? In neurogenic claudication, even standing and walking triggers in the first step, even they will get pain. Venous claudication, standing at the same place won't relieve the pain because there's a venous hypertension. Only the raising the foot will relieve the pain, right? In critical limb ischemia, ankle brachial pressure index is less than 0.5, right? That is that. And rest pain or tissue loss will be there. Rest pain, what happens is there's a forefoot pain that occurs at rest, right? Increase at night because the night other sensation will be diminished. At the same time, when you rest, this calf muscle pumping will be absent, so that there will be venous congestion that will further compromise the arterial flow. So you get more pain at night, exacerbated by elevation of the foot, relieved by lying down, hanging the leg down, right? Foot down. Usually doesn't respond to normal oral analgesics, right? That's your critical limb ischemia rest pain. And due to this severe compromisation of the blood flow, you will get minute trauma that won't heal, and there will be progression of the ulceration, right? A risk of infection as well, right? That's how you get this ulceration in ischemically. And there is a risk of dry gangrene. If it is superseded with the infection, it becomes wet, right? And Fontaine classification, stage 1 asymptomatic, stage 2 intermittent claudication, not disabling because claudication distance more than 200. Stage 2B is claudication This claudication distance less than 200. Stage 3 is rest pain and 4 is tissue loss. So stage 3 and 4 both are included in critical limb ischemia. All right. So RT imaging is needed to decide further management. No, it's not needed unless you plan for surgical intervention, right? It's not always needed because this occlusive arterial disease, peripheral vascular disease in the limb is a clinical diagnosis supported by ankle brachial pressure index. Expected ankle brachial pressure index is 0.3 to 0.5. No, this is intermittent claudication with claudication distance 200 meters. It should be around 0.8. Less than 0.5 occurs in critical limb ischemia. Right? Here, distribution suggests of critical limb ischemia, only the intermittent claudication. Revasculation is needed. Intervention is revascularization is indicated if the patient is having critical limb ischemia or disabling claudication. Here the patient is in marginal state. Can you please update this best MCQ discussion as well in YouTube? What is that? Best MCQ? I didn't get a question. Breast MCQ. Right. Intervention is needed if there's a disabling claudication or patient is having critical limb ischemia. Disabling claudication, not only with the distance, according to history, if the patient having disability, if the patient can't perform day-to-day routines due to this intermittent claudication, right? So here there is no clear indication for revascularization, right? Risk of cardiovascular event is 2 to 3 times greater than a normal individual. Yes, true. Caused by occlusion of superficial femoral artery. Yes. Pulses absent, popliteal downwards. This patient is in Fontaine 2. Yes. 2A or B, we can't differentiate because exactly the claudication distance is 200 meters. In the history, they haven't given whether it is disability to patient or not. Right? All right. Intervention is needed, and your conservative management has to be terminated if the patient is having critical limb ischemia or disabling claudication. Right? Stage 2B, 3 and 4 should be intervened surgically, either endoscopically or open surgery. Endoluminal intervention or open surgery bypasses. Right? Regarding rapid sequence induction, performed in patients with delayed gastric emptying. True. Inhalation anesthesia is used. No, you usually use IV drugs. Arterial imaging. If you go to do intervention, then you do the imaging, right? That is 2B. Onwards, you should do the imaging. Right? Usually we do the arterial duplex. Even to after diagnosis, but it's not really indicated, right? If you're going to intervene, then you have to do the imaging. Otherwise, it's not compulsory because it's a clinical diagnosis. Rapid sequence induction, usually give IV anesthesia drugs, not the inhalation. Rapid acting muscle relaxants you give succinylcholine, then cricoid, give the cricoid pressure and then intubate. Done to prevent aspiration. Yes, the emergency surgeries, rapid sequence induction is done to prevent aspiration. You put NG do the cricoid pressure, give oxymethaneum, then intubate. Is the standard practice in all pediatrics? No. Rapid sequence induction only performs in emergencies and where you get unprepared patients, alcoholic patients, emergency surgeries. You can't wait for 6 hours of fasting. Then you do the rapid sequence induction to induce GA. Right? Okay. Regarding acute kidney injury, always requires hemodialysis. False, hypokalemia, usually occurs hyperkalemia. Intraoperative hypertension is a risk factor. Yes. Pre-renal failure, it's a reason for pre-renal failure. It's not irreversible, it's reversible. Regarding clinical trials, ethical review committee reviews and clearance is not necessary when carrying out research on biopsy system. False. Experts' opinion shouldn't be taken as an evidence when managing a patient. That's false. Evidence-based medicine means you take this experience as well. BH details are taken in prospective. No, it's using retrospective studies. Results of meta-analysis of randomized double-blinded clinical trials provide level 1 evidence. That's true. Right? That's how you get level 1 evidences. Meta-analysis of randomized trials is the level 1. Randomized trials gives the level 2 evidences. Screening tests are used to diagnose clinical trials. Screening tests are used to diagnose rare diseases. We don't do clinical trials on rare diseases, right? Screening tests are used to diagnose rare diseases in population at risk. That's false. That's your statistics. Do you get statistics questions in your paper? Yes. Let me see. C false. 19C, it's used for retrospective study. Okay, right, good. Then comes the SPRs. 50 kilogram male awaiting colonic surgery. You can answer the question. What is your answer? Which of the following is most likely to reduce the risk of surgical site infection? What is the answer for this? Number 20. Yes, it's prophylactic antibiotics. These, others are shaving, sometimes increases the infection risk, right? Pre-operative nutrition, carbohydrate loading, those are also contributory factors. Mechanical bowel progression, ERS discourages. The best answer is E. Right? Prophylactic antibiotics. When you should give prophylactic antibiotics? How many minutes, hours before the incision? Anyone to answer? At the time of incision, false. The time of induction, false. Usually, what is the time duration? Induction, no. At the time of incision, that's false. That's what we do, but it's false. Yes, it's 1 hour before the. It's 1 hour, 2 hours before the incision, no? Because this antibiotics should be in the systemic circulation in a therapeutic level to act against bacteria, right? Organisms. So it should be in the circulation. Once you give the drugs, it won't come to the therapeutic range in the systemic circulation within minutes. So there should be a window period to act, right? That is the idea, right? 21. A 45-year-old school physical training teacher presented severe headache, palpitation on exertion, which was recent in onset. On examination, blood pressure is 190 by 110. and pulse rate is 105. No papillary edema, focal neurological signs. What is the most appropriate investigation to diagnose? What is this clinical picture? You want to answer this? What is this clinical picture? Pheochromocytoma. Yes. What is pheochromocytoma? What is pheochromocytoma? Team of the adrenal gland. At which part? There is a medulla and the cortex. It's medullary tumor, no? And it secretes. What happens in pheochromocytoma? What is the excessive hormone there? Adrenal tumors, right? Epinephrine, yes. Okay, right. Adrenal tumors. Adrenal medulla secretes catecholamines, the cortex secretes aldosterone, cortisol, and androgens, right? And this clinical presentation of adrenal tumors, there can be features of hormonal excess, features of tumor burden, and incidental hormone, right? Adrenocortical hormone excess. If there's aldosterone secreted tumor, that will manifest as hyperaldosteronism. There are cortisol secreted tumors. Patient comes with Cushing's, right? And if there's adrenomedullary hormone excess, adrenomedullary tumors, then patient present with this epinephrine excess. That's why you get picture of pheochromocytoma, right? In pheochromocytomas, 3 P's: pressure, palpitation, perspiration. Sustained paroxysmal hypertension, headache, palpitation, sweating, pallor, nausea, flushing, weight loss, psychological symptoms, orthostatic hypotension, hyperglycemia, and sudden release of catecholamines, life-threatening crisis can be developed, right? And morphological pheochromocytoma is a catecholamine secreting tumor. 80 to 85% it's due to adrenomedullary tumor. 15 to 20% it can be extraadrenal profane tissue, right? Paragangliomas producing noradrenaline. 10% of tumors are bilateral, 10% are malignant, 10% in children, 10% are extraadrenal, 10% hereditary, 10% hormonal inactive, right? Sporadic forms occur in 4th decade. There's genetic component as well in men to get mutation ret proton gene, right? It can associate with primary hyperparathyroidism and medullary thyroid carcinoma in men 2A, men 2B, morphoid picture, ganglioneuromas, medullary thyroid carcinoma, and then comes pheochromocytoma. There are associations with Montgomery syndrome, neurofibromatosis, right? Investigation, biochemical investigation, 24 urinary fraction catecholamines, epinephrines and norepinephrines, and their metabolites will be assessed, right? Then you can check the plasma-free metanephrine and dopamine levels as well. Imaging, MRI preferred was CT. Right. Management, there is a surgical, and if it is unresectable, then comes the radiotherapy and medical treatment. Right, that's regarding pheochromocytoma. And they give history of no, in the history they give no papilledema, focal neurological signs. That is excludes brain pathology, right? Hypertension is there, palpitation, headache, right? Most appropriate initial diagnosis, then comes to your 24 urinary collection for metanephritis, right? Answer is E. Right. Question number 22. 20-year-old man presented wrist stroke following a road traffic accident. There are no collateral injuries. He can't recall the details of the impact. On examination, there was impaired sensation of the anatomical snuff box, impaired extension of fingers at the metacarpophalangeal joints. All the upper reflexes are preserved. What is the anatomical side of the lesion? What is the answer for this? Yes. Yes, it's there's a wrist drop, right? Patient comes with a wrist drop. In the examination, impaired extension of the metacarpophalangeal joint as well as the wrist drop. That means extensors of the wrist also impaired. So the lesion should be above the elbow because at the elbow level, radial nerve gives the supply to the extensors, right? So lesion should be above the elbow level. So answer should be C, right? This is the picture you get in even in the Saturday night pose. You get the neuropraxia, your radial nerve get compressed against the shaft of the humerus and get neuropraxia, right? As reflexes are preserved. Reflexes are preserved mean you have this triceps and biceps joint. That means you biceps radial nerve supplies the triceps. So it's below the axilla, above the elbow, right? That's how you get work out it. Triceps jerk is preserved means triceps, this radial nerve supplies triceps, right? Right. 23, 54-year-old farmer injured his leg while farming and 4 days later presented swelling of the leg with brownish discharge and crepitus. Most likely infection. What is this clinical picture? Before the answer, what is this clinical picture? Gas gangrene. What is gas gangrene? What is gas gangrene? So type of necrotizing soft tissue infection, right? What are the types of necrotizing soft tissue infection, you know? What is necrotizing fasciitis? 4 years gangrene. This necrotizing of lower limb. And what else? This is upper external peripheral nerve syndromes. Yes, here the article in up to date. Necrotizing soft tissue infection include necrotizing forms of fasciitis, myositis, and cellulitis, right? These are clinically characterized by fulminant tissue destruction, systemic signs of toxicity. They get septicemia and septic shock, and there's a high mortality, right? You should diagnose early and intervene early, right? Antibiotics and surgical interventions are the mainstay of treatment. Necrotic fasciitis is an infection deep tissue, right? It progressively destruct the fascias of the muscle, right? First, they involve the fascia of the deep fascias of the muscle, and deep fascias will be necrosed. And later, it involves the muscles as well. If those muscles are involved, that is called myonecrosis, right? Then those infection can be due to gas-forming organisms, right? Anaerobic organisms. Necrotic fasciitis may be divided into two microbiological categories: polymicrobial and monomicrobial. Polymicrobial can be aerobic or anaerobic, right? Then necrotic myositis, infection of the skeletal muscle, right? Then again, necrotic cellulitis. It's typically caused by anaerobic pathogens, may be divided into two types: clostridial and non-clostridial. Clostridial perfringens is the one that causes this Clostridium myonecrosis, where you get the gas forming. There will be gas trapped in the tissue planes. You get the crepitations, right? And if you get a polymicrobial infection with gas forming organisms, again you get crepitations. But commonly due to this Clostridium perfringens, right? Clinical manifestation of necrotizing infection: erythema, edema that extends beyond the visible erythema, severe pain, fever, crepitus, and skin bullet, right? Those Phonius gangrene, head region, the severe soft tissue infection which leads to necrosis, and gas gangrene is one of them, right? Surgical exploration is the only way to establish the diagnosis of necrotizing infection, because you can't see sometimes from the outside because all and skin will be hazy, but there will be deep infection which progresses, right? If you do a CT, then you can see the gas. If there are gas forming organisms and if the gas is trapped within the soft tissue, you can see it by CTs, right? Gas gangrene, clostridial myonecrosis, the acute invasion of healthy tissue that occurs spontaneously as a result of traumatic injury. Both gas gangrene and polymicrobial necrosis of tissue infection associate gas in the tissues. Gas gangrene gram stain typically demonstrates gram-positive rods. The distinction is important in the management of Clostridium myonecrosis. May require amputation, where management of necrotic fasciitis requires debridement. Usually, this Clostridium myonecrosis is very devastating. You should do the amputation to prevent the septicemia. And if you want to save the patient, you should do the amputation. That is the clinical significance of gas gangrene, right? And the organism is Clostridium perfringens, right? That's it. So answer is C. Right. Then 24, 60-year-old cirrhotic patient comes with hematemesis. He's conscious, rational, pulse rate 90, blood pressure 100/80. What is the best management option? What is the answer for this? 24. Grouping and cross-match should be done, right? That should be included in your answer because there's a bleeding. You should transist, no? If there's ongoing bleeding, and if the patient is anemic, right? For the time being, patient is stable, pulse rate is 90, blood pressure 100 by 80. So IV access should be gained, grouping and cross-matching should be done, and definitive treatment depends on the definitive treatment is doing endoscopy and intervene, right? So the answer is D, right? Because you should do the grouping and DT cross-matching. That is an essential component of your recitation here, right? You get the IV cannula in, take the blood for investigation and grouping and cross-match. Right? Pancreatitis also has a place, but best answer is D. Right? 25, 60-year-old lady with persistent dyspepsia for 2 years and treated for pulmonary TB 10 years back, presented loss of appetite and anemia for 2 weeks. Purgia shows ulcer with everted edges, necrotic material with contact bleeding. What is the most likely diagnosis? 60-year-old oral lady, right? Loss of appetite, anemia, background history of dyspepsia for 2 years. What is your diagnosis here? Answer? What is the answer? Yes, answer is B. Unless proven otherwise, it's gastric cancer, right? This ulcer is also with everted edges with necrosis. And background history of loss of appetite, right? And dyspepsia means there should be ongoing chronic inflammation of stomach, right? Gastritis picture. So it's a risk factor for developing gastric carcinoma, right? Answer should be B. This GIST and the lymphomas are the pathological diagnosis. TB ulcer usually have inverted edges, right? 26, 40-year-old female patient presented abdominal pain and bilious vomiting. She has undergone surgery for small bowel perforation 5 years back. She has gallstone disease. What could be the reason for this time presentation? What is this clinical condition? Patient comes with abdominal pain and bilious vomiting. Past history of small bowel surgery following a perforation. What is the clinical condition? Intestinal obstruction. Yes. Intestinal obstruction. Which level? What is the this vomiting is more predominant? Is it large bowel obstruction or small bowel obstruction? Small bowel, yes, because vomiting is predominant in the large bowel obstruction, there will be distension, right? What is the most common cause for small bowel obstruction? Most common cause for small adhesions, yes. There's a history of past surgery due to perforation, so the best answer should be adhesions. Gallstone ileus also answer, but best answer should be A, right? Gallstone ileus is rare, right? Pancreatitis you get in this after surgery or electrolyte imbalances. They haven't given history suggestive hernias, right? So best answer should be A. 64-year-old lady who is a history of altered bowel habits, presented sudden onset vomiting, lower pain and abdominal distension. On examination, there's a left iliac fossa lump. She had similar episode 1 year back. History of altered bowel habits, presented sudden onset vomiting, low abdominal pain, abdominal distension. There's a left iliac fossa lump. Right? What is the probable diagnosis? What is this clinical condition? Most probable. They say, there's a question, they say gallstone disease in the previous question. This is just to misguide us. Yes, because then they want to check what do you choose. You should always choose common things first. No? Osteomyelitis is a possibility, but most common thing is there's a background issue of surgery, uh, bowel obstruction, perforation. That means there should be cross-contamination. So more risk is to develop adhesions and get this small bowel obstruction rather than ileus. Right? That is regarding question number 26, 27. Yes. With regard to this clinical picture, locally advanced left colonic cancer. How do you take it out? Because there's a history, civil history 1 year back. This long this picture runs over a reasonable duration. So cancer is out, right? Acute pyelonephritis, again you have this urinary symptoms, fever, chills and rigors, right? So it's out. Ulcerative colitis, severe fulminant ulcerative colitis. Again, you have this PR bleeding. It's also rare form of disorder, severe ulcerative colitis. And there should be more lower GI symptoms, right? Left tube ovarian abscess again. Here the history gives this GI symptoms, abdominal distension, lower abdominal pain, vomiting. So diverticular mass is a good option, right? This should be the answer. It can be sigmoid volvulus again present with the features of bowel obstruction. Yes, anything can be this diverticular mass, sigmoid volvulus even is possible, but you have to choose the best answer out of the given answers. No? So diverticular mass is the best within these 5 answers, right? Right. 25-year-old male present with painless fresh bleeding per rectum for 2 weeks duration. What is the most likely diagnosis? What is the answer for 28? Yes, painless bleeding. Most of you all have answered hemorrhoids. With anal fissure, it's painful. Rectal carcinoma, again, they haven't given the DRE findings. There should be lower GI symptoms with things such as irregular bleeding, PR, this tenesmus, right? Anal carcinoma, again, it comes with a lump. There should be positive DRE findings. Painless fresh bleeding. Considering the age also, most likely diagnosis hemorrhoids, right? Carcinomas are more common in old age. Anal fissures again common in this age, but it's painful. 11 months old child with tender, tense right inguinal lung. On examination, child is irritable and abdomen is distended. What is the best management? What is the answer for 29? What is this clinical picture? What is the clinical picture? There's an obstructed hernia, right? Tense right inguinal lung. There's abdominal distension. Patient irritable. There's obstruction, possible impending strangulation as well. So you should resuscitate the child and then do the emergency surgery. Manual reduction is out, right? Patient is ill, the impending obstruction. Resuscitation and emergency surgery should be the option. Question number 30, 70-year-old woman presenting with recent change of pigmented patch over her left cheek, which has been there for 15 years. On examination, it is thick and has an irregular border with central nodularity. What is the diagnosis? In adults, there's a question. In adults, do we do concealed management? There's a question regarding adult hernias. do the consideration for obstruction? Yes, we try to relieve the pain. And if it is only obstruction without bowel ischemia or perforation, you can just try consider methods: pain relief, packing, elevation of foot 10, keeping ice, right? And you do ABG and look for lactate levels to assess degree of ischemia. If there's no evidence of this strangulation, then you can try consider measures before you go for surgical intervention. Here, what is the answer for question number 30? Why do you say melanoma? Why it is not basal cell carcinoma? Considering the anatomical region, it's more towards basal cell carcinoma, right? Basal cell carcinoma appearance, it could be a nodular cystic pigment, right? Specific sites, preorbital, nose, perioral, nasolabial folds, pre or post auricule, right? And more in men, slow growing, local invasive malignant tumor, rising from basal epidermis and half follicles, right? 90% lesions are found in the face, above a line from the lobe of the liver to the corner of the mouth, rarely metastasis. Like a melanoma, yes, there are those two answers are both the answers are very close by, right? But considering this clinical picture, basal cell carcinoma is also good option, good possibility. Clinically, we can't differentiate. That is the problem. In nodularity, you get even in both the melanoma and basal cell carcinoma. Probably they have something missing in the question, right? You won't get such a, if there should be clear clinical evidence to decide, no? So there should be something missing in the question. Given the scenario, basal cell carcinoma and melanoma both are possible. That's that. Anyway, you read about melanoma and basal cell carcinoma, get the knowledge. In the question exam, they'll give more clear stems, right? Yeah, they have collected from the paper. I think some parts are missing. 31, 50-year-old female patient presented deep jaundice, colic abdominal pain, fever for 3 days. What is his trial? Deep jaundice, abdominal pain, fever. She's undergone lab coli for symptomatic gallstone disease 2 weeks ago. What is the most likely diagnosis? What is the answer for 31? Is this Charcot's trial? What is the answer? What is the answer for this? Most of our answers are benign biliary stricture. Why? Why did you choose as stricture? It's not following, it's following cholecystectomy, right? Common picture is retained stone in the bile duct, right? That's how they present. There's a stone slipped into the common bile duct, and they develop obstructive jaundice later, complicated with cholangitis. So R should be D, slipped stone from the gallstone into the common bile duct, obstruction. later becomes infected, right? Because it's painful jaundice, right? And following a lap coli, retained stone in the bile duct should be the answer. Okay. Right. Then 31-year-old female in 7th week of postpartum presented tender erythematous lump in her left breast for 3 days duration. On excision, it was a tender and fluctuant. What is the most appropriate management? Before management, what is this clinical condition? 32, postpartum 7th week, erythematous tender lump. There's a fluctuation, tenderness. What is the diagnosis? It's breast abscess, yes. How do you manage breast abscess in postpartum period? What is the management? What is the answer for this? Yes, repeated ulcer aspiration. Ulcer, yes. That's it. Answer is C. We have discussed this question in our previous MCQ session. Right. 33, 70-year-old woman presenting with right-sided solitary thyroid nodule, which turned out to be a folliculation on FNS. The rest of the thyroid gland was normal on ultrasound. Most appropriate next step of the management. What is the answer for 33? Yes. You should reach a histological diagnosis. FNS can't differentiate follicular adenoma and carcinoma. So you go for hemithyroidectomy. Okay. 34, 55-year-old smoker presenting with painless upper neck lump for 2 months duration. No other symptoms. Lump is firm, upper cervical lymph node. Something missing in the question, right? FNS suggests malignancy. What is the most suitable investigation to arrive at a diagnosis? What is this clinical scenario? What is this clinical scenario? Carcinoma of unknown primary. Yes. So something missing in the question, right? What they have missed? This is a clinical picture of carcinoma of unknown primary, right? If the FNAC comes as squamous cell carcinoma, then you should suspect, then you go with the pan endoscopy, right? Screening the both the aerodigestive tract, that's the lung, trachea and the lung, airway, trachea and the lung, then the GI tract. Here they haven't given the FNAC findings, they just gave the malignancy. If it is adenocarcinoma, again, you should think about this breast CAS and GI carcinomas, then you go for immunohistochemistry. If it is squamous cell carcinoma, no point of taking histology. You should do the pan endoscopy, right? That is the 2 ways of investigating Cup syndrome, carcinoma of unknown primary. Here they haven't given the FNAC findings. They just say malignancy. So we can't give an answer. Carcinoma of unknown primary is histologically proven metastatic malignant tumor whose primary site cannot be identified during pre-treatment evaluation. Right? That is your primary carcinoma of unknown primary. You have a lymph node, you do a FNAC, there's metastatic cells, but you can't find a primary site. Right? Characteristic of these tumors: early dissemination, aggressiveness, unpredictability of metastatic pattern. Cup presentations, lymph node metastasis, visceral lung mets, liver, brain, thyroid, or peritoneum mets, right? And regarding this assessment, you do all this stuff, right? But if it comes as a squamous cell carcinoma in FNAC, then you go for the pan endoscopies, right? And if it is adenocarcinoma, then you go for immunohistories. That is the two lines of this is the management FNAC. Results can be squamous cell carcinoma, adenocarcinoma, anaplastic thyroid melanoma, lymphoma. If it's squamous cell carcinoma, poor differential squamous cell carcinoma, non-keratinized squamous cell carcinoma, investigate further with where's the endoscopic evaluation, right? That is two lines. I think I don't know whether you will have taught about this endoscopic evaluation of aerodigestive tract, right? If it becomes, if FNAC becomes, if FNAC becomes adenocarcinoma, endoscopic evaluation of the aerodigestive tract, as same as its SSC, excision biopsy and do immunohistochemistry to find the primary tissue, right? So here in the question, they are given the pan endoscopies, no? They just give bronchoscopy, fiberoptic nasal laryngoscopy, all the parts. In the pan endoscopy, you do everything. And if it is squamous cell carcinoma, answer should be FNAC findings of squamous cell carcinoma. Answer should be pan endoscopy. If it is adenocarcinoma, pan endoscopy plus immunohistochemistry. Right? That is how you find the primary site, right? Okay. The third question number 35. 69-year-old female presented with polyuria, polydipsia, and abdominal pain. She has been having recurrent urinary tract stones. What is the next investigation, diagnosis, problem? What is his clinical presentation? 35. What are the symptoms suggestive of? Diabetes, not diabetes, this is hypercalcemic features, right? What are the features of hypercalcemia? What are the clinical symptoms and signs of hypercalcemia? This clinical presentation: bones, stones, abdominal groans, and psychic bones, right? In severe disease, you get renal stone, pancreatitis, and psychiatric illness. Okay. It can be due to like hypercalcemia can be due to primary hyperparathyroidism, but most common pictures due to metastatic bone tumors, right? Bone metastasis. Stone bones and groans, yes. You get this polyuria and polydipsia as well, right? And investigate, you do the calcium studies, then go for parathyroid hormone levels, right? The question: what is the next investigation, diagnosis problem? What is your answer? What is the next investigation? Diagnose you should do serum calcium, then investigate with then find the cause, right? You confirm this is the hypercalcemia, then find the cause, right? You can't diagnose by this. Probably they have asked for the next investigation with regard to analyzing of this problem, right? Without confirming the hypercalcemia, you can't do anything. No? So answer should be B. There are problems with terminology discussions because students have some local university exam questions. They have memorized and formulated the question. So there are some errors. Next investigation should be serum calcium, right? Get the idea, get the clinical picture and pattern of answers, then same questions will be in your exam. Right. Then question number 36, 74-year-old lady who is having postural hypotension and recurrent falls presented to the ward following a fall with a shortened left leg, which was externally rotated. X-ray showed an intercapsular necrothoracic femur fracture of the left leg. What is the most appropriate treatment of this patient, for this patient? Why do they get this external rotation in fracture? What is the clinical, how do they come with the hip dislocation? What is the position of the leg when there's a hip dislocation? There is interrotation, right? Yes. In the gluteus contracts, so adductors work to cause external rotation in fractures. Yes. Okay. Then what is the significance of necrothoracic fracture, intracapsular versus extracapsular fracture? Clinical significance? Anyone? If it is an intracapsular fracture, there is a head will be necrosis. There's a avascular necrosis because this retinacular vessels goes through the capsule, and then when the capsule breaks, all the blood supply of the head will be cut down, and there will be avascular necrosis of the head, right? If it is extracapsular fracture, blood vessels will be preserved, right? Blood vessels won't be damaged, so the head won't be necrosed. You can fix the fracture and fracture will be healed. But if the head is necrosed, you have to take that necrotic part out and put a artificial head. That's what you do in osteomyelitis hemiarthroplasty. But if it is a young patient, you can't do a hemiarthroplasty. You should do a total hip replacement. You should replace the acetabular fossa with artificial cup as well. Otherwise, this osteomyelitis hemiarthroplasty usually duration is 10 years. After that, due to this artificial head, acetabular fossa will be eroded, right? So if it is a young patient with intracapsular necrothoracic fracture, you should confirm the avascular necrosis by CT. Then you should do a total hip replacement. If it is extracapsular fracture, then dynamic hip screw will be the management, right? That's that. Right. So the answer should be C, hemiarthroplasty. That is osteomyelitis hemiarthroplasty. What is the age limit of AMH? You do, if the life expectancy is 10 years or less, you do AMH. Otherwise, better do a THR, total hip replacement. Right? That is the idea. Because if you put a osteomyelitis hemiarthroplasty, that's a metallic head now, that will, if in the long run, it will erode the bone. Okay. That's it. Do you know the blood supply of the femur head? You're familiar with that? blood supply. This right? You get this medial and lateral circumflex arteries, and you have these branches runs along the capsule of the hip joint, right? If you get intracapsular fracture, capsule will be torn and all the vessels will be damaged. This in the young age, you get this blood vessels along the ligamentum teres. Those are rudimentary when it comes to the adults, right? And what are the other bones? You get this avascular necrosis after fracture. What are the other bones? You get avascular necrosis after fracture. Scaphoid, yes. Other one? Scaphoid again, blood supply comes distal proximal. If there's fracture, proximal segment will be necrosis. Other bone? You get avascular necrosis. Anyone? Talus, again, you get avascular necrosis, right? Okay. Someone has Hansi has answered. Tell us. Yes, good. Right. Then question number 37. 60-year-old presented swelling of the lower one-third of the left thigh for 2 months duration. She has a low-grade fever. On examination, she has a hard lump over one lower one-third of the left thigh, which is warm to touch. X-ray revealed lesion arises from diaphysis of the femur with onion skin appearance. What is most likely diagnosis? Yes. Someone's answer. Event sarcoma. Yes. This is the standard is this clinical picture of the event sarcoma. You get this. This is the onion skin appearance, right? This is the radiograph onion skin in a wind sarcoma. Periosteal reaction in epilateral view of the distal femur. 50-year-old. This is up-to-date pictures, right? Multiple layers of periosteal reactions simulate the appearance of layers of an onion skin. Right? Multiple layers of periosteal reaction. Right? Disruption of outermost layer of the soft tissue and the soft tissue mass suggested for malignant process. This is soft tissue mass, right? Disruption of outermost layer. Okay. Having sarcoma. Clinical family tumors. Signs and symptoms. Patient typically presents localized pain or swelling of a few weeks or months. Trauma often minor, maybe the initial event that calls attention to the lesion. Pain may be mild at first, but intensifies fairly rapidly. May be aggravated by exercise and often worse at night. Distinct soft tissue mass can sometimes be appreciated. When present, it is usually firmly attached to the bone and moderated to markedly tender to palpation. Swelling of the affected limb with erythema over the mass is not uncommon. This is the clinical picture, exact clinical picture given in the MCQ, right? Consider symptoms or signs such as fever, fatigue, weight loss, anemia present approximately 10 to 20%. Right? And this onion skin appearance X-ray is a pathognomonic. Right. That's your having sarcoma. Usually arises in the distal femur and proximal tibia, right? 38, previous healthy male was diagnosed with 2 centimeter renal stone in renal pelvis. Density is 1350 ounce field units. Yes, episodic pain and hematuria. This symptomatic large stone in the renal pelvis and high density. Best management option. What is the answer for 38? Yes, PCN. Why not ESW? ESW is out because larger stones and high density Hounsfield units, right? More than 1,000. Larger stones are unfavorable factors. So ESW. So best option is PC, percutaneous nephrolethotomy. If it is failed, then you go for open surgeries, right? Pyelithotomies and everything. Medical expulsion therapy anyway out, right? Again, this 5-year-old boy presented with empty right hemiscrotum on examination. A normal size testis was palpable in right inguinal canal, which could be easily manipulated to the scrotum and stays there without traction. What is the most likely diagnosis? What is the answer for this? It's retractile testis. You can easily take the testis into the scrotum without traction. It stays there without traction. What is ascending testis? Huh? What is ascending testis? Probably goes up. That is where you get this higher growth rates, right? Your gonadal cells are more than the rate of gonadal cells. Body grows up and the scrotum goes up relative to the testicular vessels. So testis remains. Testis initially retains in the scrotum, later goes into the inguinal canal. That is what is called ascending testis, right? Definitions. Testis has been in the scrotum once, but if the body grows faster than testicular vessels grow, testis gets ascends up into the inguinal canal. Gliding testis can be brought down to the scrotum, but immediately it goes back. That is gliding testis, right? Retractile testis, you can take the testis into the scrotum, it remains in the scrotum without traction. In ectopic testis, the testis in the base of the penis, perineum or medial there, away from the normal descending line, right? And there was another terminology, the question, this transverse testicular ectopy. It's a rare condition where both the testis ascend in the same inguinal canal and lies in the same hemiscrotum, right? That's it. Terminology. Question 40, 53-year-old man, post-op 5th day following knee replacement surgery, developed pulmonary embolism. Which is the most appropriate management? What is the answer for this? Question number 40. Yes, it's therapy dose of anticoagulation, right? And thrombolysis, systemic thrombolysis anyway contraindicated after major surgery. So do a thrombectomy, it should be targeted. You should reach the thrombus and do the thrombectomy, right? Placement of IVC filter is any out now. Patient has developed pulmonary embolism. It is for the prevention of complication of DVT. Prevent the pulmonary embolism in DVT patients, you place the IVC filter. Dual antiplatelet therapy is anyway again out, right? So the answer should be D. 41. Which of the following is the best indicator of survival of a transplanted organ? This is again a question with the confusion, right? ABO compatibility, HLA compatibility, both are matters, right? ABO compatibility, you can achieve easily. HLA compatibility is the thing you can't achieve. You should do the screening, right? But both are important, right? If you don't get a ABO compatibility, you will get a hyperacute rejection. If you don't get HLA compatibility, you get this acute and chronic rejection. So both are important. Which of the following is best indicator of survival? You can't take one from these two, right? There should be something missing in the question. And both are important, right? If you forget ABO compatibility, you get hyperacute rejection. If you don't get HLA compatibility, you again get acute or chronic rejection, right? And you get this rejection of organ transplantation because body identifies foreign tissues from the self tissues and try to reject, right? There are barriers for successful organ transplantation. So biological hurdle, that is immunological barrier, surgical and medical barrier, right? And you get this ABO compatibility and HLA compatibility both, right? And unlike ABO antigens, HLA antigens significant barrier to clinical transplantation because there are variations, right? You have to match. But ABO compatibility you can achieve easily, right? But both are important. You can't choose one from the other, right? Both are important when it comes to survival. Okay. Different blood groups as the patients. If you can't explore ABO and take HLA as the answer. Different blood groups is still ABO compatibility should be there, right? You can't forget ABO compatibility. HLA and ABO compatibility both should be there, right? If you don't get ABO compatibility, you get hyperacute rejection, right? Presence of preform antibody, anti-HBO, anti-ABO in high volumes. That is the reason for hyperacute rejection. Right, we are rushed now. There are a few questions more. We'll go. So you can't get an answer. Right? 42, 30-year-old man presents history of thrown prick to right index finger 3 days ago. Now presenting throbbing pain and swelling at that side. What is this clinical condition? What is the management? What is this clinical condition? What is clinical condition? Where is the infection? Do you know the hand spaces? What are the spaces you know in the hand? It's a pulse space infection, right? If there's a high pressure developing in the pulse space, there's a risk of avascular necrosis in the distal part of the phalanges, right? Distal phalanx, right? So you have to decompress and release the pressure. And there are hypothena, thin and mid palmar spaces. In the forearm, there's a space of Parona. All are potential spaces for infection, right? So read about those hand spaces. And here the infection is in the pulse spaces, pulse space of the index finger. You should do the IND, right? Otherwise, during infection, there will be pressure within the pulse space, and which leads to compression of blood vessels, which supply the distal part of the phalanx, and there is a risk of necrosis, right? Okay. And if I can show you pulse space. Fingers, right? This is your pulse space. There are septate fibrous fat compartments. Due to infection, there's increased pressure, and the distal part of the distal phalanx supplied by the blood vessels traverses from the proximal part of the pulse spaces, right? So you get blood supply to proximal part of the phalanx, but distal part will be ischemic. If there's an increased pulse stress pressure, there is a risk of avascular necrosis, right? So in the pulse space infection, you should intervene early and decompress, right? That is the idea, right? So IND is answer. Male presented colic abdominal pain and absolute constipation for 4 years. Which X-ray sign indicates immediate laboratory? Answer for 43. Yes. D. Dilatation of cecum. Cecum diameter more than 9 centimeter means it's dilated and high risk of perforation, right? It's like a closed loop obstruction. So D should be the answer, right? 44. 60-year-old man with a there's a 60 kilogram man should be, right? It's not the age. With a 10 centimeter laceration on his right forearm. What is the most suitable local anesthesia suture the wound? How do you calculate the local anesthesia volume according to body weight? If it is 60 kilogram, what is the plain lignocaine dose for a 60 kilogram male? 3 milligram per kg. Yes, 3 milligram per, not a milliliter, 3 milligram per kg. What do you mean by 1% lignocaine? 1% lignocaine? What these percentages mean? 1%, 2%. 1% means 100 ml contains 1 gram in 1%. Okay. In 2%, 2% means 100 ml contains 2 gram, right? What we usually give is 1% lignocaine, right? There you get 1 gram in the 100 ml. That means 1000 milligram in the 100 ml. 1 ml contains 10 milligrams, right? In a 60 kilogram male, maximum dose should be 3 milligram per kg means for 60, 180. So 180, right? Then 1 ml contains 10 milligram means maximum dose should be 18 ml. And that is your calculation. That is your maths, right? So answer should be A. If you give 1% lignocaine, 18 ml, right? And lignocaine with adrenaline, that is 7 milligram per kg. Dose bupivacaine again, bupivacaine also same as plain lignocaine, right? So you can try the calculation, right? It's your mathematics, nothing else. Man fallen from height, neck pain, and all 4 limbs weakness there. All limbs are weakened. Upper limb weakness more than the lower limb, and sensory loss more in upper limbs. What is this clinical condition? What is this clinical condition? Fallen from height, quadriplegic. There's a spinal cord, cervical spine injury, and this clinical presentation is, as Anaya said, central cord syndrome. Upper limbs are affected more than the lower limbs, right? So that is, and central cord, it's not, what is it? It's central cord, yes, central cord syndrome, right? Read about this anterior cord, central cord, cord equina, complete transverse myelopathy. Spinal shock, you get this hypertension, bradycardia due to sympathetic denervation, right? That is again a common presentation following C-spine injury, right? So the answer is B, central cord syndrome. You get this 12 past 2 will finish. Central cord syndrome, upper limbs are affected more than the lower limbs because central part of the cord gets affected. This is due to hyperextension injuries of C-spine. Upper limb fibers are located centrally compared to lower limb fibers. So central fibers are affected more, upper limb signs are more prominent. When the blood supply spinal cord is transiently affected, deeper tracts get more affected, hence upper limb involvement is more than the lower limb. That is the rationale, right? Right. Then 46. 55-year-old smoker presents cough, recent weight loss, partial ptosis, and left supraclavian lymph node enlarged. What is the most positive chest X-ray feature of malignancy? What is his clinical presentation? Smoker, cough, weight loss, ptosis. That's supraclavian lymph node. There is a clinical picture of what? Pancreatitis. Yes. Definitely. The Horner syndrome. So, what is the most suggestive chest X-ray suggestive malignancy? All are unspecific. Superior intestinal widening, lung cavitation, upper lobe color, all are possible in malignancy. But elevated right diaphragm you get in this nerve infiltration, right? Chronic nerve infiltration. So answer should be B. Widening of superior intestine, any mass in the mediastinum can give rise. Presence of lung cavitation, that is one infection. Upper lobe collapse again can be due to compression by tumor, but it's not specific again. So answer should be B. Right. 47. Previously, the 18-month-old child stays in a separate room from family members. Experience hard onset cough. It settles out few minutes. Child appears normal but has drooling of saliva and refusal to feed. What's the most probable diagnosis? What is the answer for 47? 47. Answer 47. Why D? Why D? Yes, there's no respiratory stress. Problem is whether it is foreign body in piriform fossa, foreign body in esophagus, right? In piriform, this drooling of saliva and refusal to feed common when there's a foreign body in esophagus, right? And epiglottitis patient will be ill, right? And there will be stride upper impending upper obstruction. GRD, why not B? This drooling of saliva is more and refusal to feed prominent in esophageal foreign bodies, right? Piriform fossa, you don't get this obstruction. Right. 48, 50-year-old man presented acute painful life. Which of the following is an immediate ophthalmology referral? This condition which leads to it threatens the vision. What is the answer for 48? That's the ophthalmology question. Surgery. What is the answer for that? Corneal abrasion, episcleritis, photophobia, conjunctivitis, circumcorneal injection. Answer should be B, right? That is what occurs in the glaucoma. Angle closure glaucoma, no? Circumcorneal injection. Right? You go and check with your ophthalmology notes. These should be the answer, right? Others are conjunctivitis, abrasion, scleritis, photophobia. Those are not eyes threatening condition for eyesight, right? Vision. Here this is due to angle closure glaucoma. It's an ophthalmology emergency. There would be presentation of glaucoma, right? 49, 60-year-old diabetes patient was found unresponsive in ward. No breathing movements. He was having sinus bradycardia. What is the most important next step in the management? Patient unresponsive, no breathing. What do you want to know now? Yes, you should know whether the patient is a cardiac arrest or not. Check the pulse, right? Central pulse, it should be central pulses. So it should be C. Right. Then, yeah, that's it for the day. And anything in the thing. Yes, we are going to do this topic wise revision. If anyone is interested, can join. We are going to start from next Monday. We'll touch on each and every most of the surgical topics, right? We'll try to cover entire syllabus. Right. Okay then. That's for the day. If you all have any questions, you can always post it in the group. Right. Any question on this paper? Okay. Right. And that's it. Good night.